Hello and welcome. My name is Diane Bloomfield. I'm a general pediatrician. I work at the Children's Hospital at Montefiore in the Bronx. And I have the honor of taking care of children and families and also working with individuals as we learn to take care of them when they're faced with mental health challenges. I love my job. I'm lucky today to be joined by two wonderful women who are going to help us learn how we should do things better in our practices. Sarah Farmer is a community volunteer with experience as an analyst and a teacher. She and her husband have two sons, one in middle and one in high school. Must be busy in your house. And she's also a family partner at the American Academy of Pediatrics. Amy Rachel, LMSW, is a dedicated social worker and also a family partner for the AAP. She is also the mother of 5 children, 2 of whom were adopted after experiencing significant prenatal substance exposure. Both of my women here today are drawing on their professional and their lived experience, and they're going to bring a unique perspective to how we can support families as they navigate complex systems of care. Now, today we're talking about shared decision making and how we can do a better job in our practices. I think that we'd all agree this is an important topic because that old model of the doctor just bopping into the room, telling you what to do, and then bopping out and expecting you to do that, thankfully is in the past. Nowadays, we've learned that it's really important that we hear from the families. The AAP says you're supposed to look for more than one medically reasonable option when you talk to families. But the work really starts when the pediatrician seeks to understand the family's values. What are their thoughts about the options? What do they want to consider? What are their priorities? I always want to figure out how to do the best shared decision making, especially when I'm dealing with a sensitive topic, such as a mental health condition. So what I'm hoping my experts can help me with today are how do they prefer that we talk to families about mental health? What would they like us to know about the family before we start giving advice? What would they like us to know about their lives, their schools, their resources, the support systems, and the strengths that they already have? So Sarah and Amy, what does shared decision making to you mean to you? And what does it look like when it goes well, and what does it look like when it doesn't?
Hi, Diane. Thank you so much. As far as what looks like good decision making or shared decision making, it is always helpful when a pediatrician volunteers that, because while some families understand and will ask for that, there are other families with experiences who might be afraid to ask for that or not even know to ask those questions. So having the pediatrician or the provider being willing and able to ask the first questions and open that up as a topic is even the first important place to start, I'd say. Amy, what are you thinking?
Yeah, I think really creating safety and giving context for families, really setting up this trust with their provider before we ever even have to have those conversations is really our starting point for me.
Okay. Well, when is it best for a pediatrician to ask about your family? I always feel bad asking about issues when we're in the middle of a crisis, right? So what would be your advice?
For me as a parent, I think, of course, when crisis hits, we kind of feel like the floor has fallen out from underneath us, or we're juggling fear and anxiety. We are flooded with information that we're trying to process. So, right, in that moment would not be the time to figure out what kind of decision making that we have, because that would not be collaboration. You wouldn't understand where our family is coming from. So I think before any of that ever even happens, you're having our intake, our first initial visit, and that is when you're beginning that building of that trust. And you're letting me know that all families have stressors. And so then I don't feel like you're pointing me out as a family who may have a lot of stress, but that you're really starting to build a bridge that I can come to you whenever something is happening or I feel like something's amiss with one of my kids. We've built that trust and we've built this partnership in helping raise these kids that then I could come to you. So I think it starts even on the very initial intake.
I'd add, this is relational. I think most people who get into pediatrics are getting in for a relationship. And there are times when people move, families move, or any other reason where you aren't getting a baby as the intake. But whenever you are first having that family come in, having little questions at every visit, a couple notes here and there that build that relationship over time, so that when something, whether it's mental health or physical health, something comes up that is a little tricky or sticky, the family feels a relationship and the provider feels a relationship. So you're not asking really from point zero. You may have some idea of how does that family respond to stress? How does that parent take on information, and how willing are they going to be to talk? So just making sure that there is a foundation of trust, of a relationship, that will make any conversation go more easily.
Well, that's great advice. So we should really start early when we first meet the family, right? What do you think about letting us know about the strengths that your family has, so that we know in advance things that you can rely on when it's time to work together for an issue? How do we tease that out? What's a good way to bring that out?
I think for some issues, it's understanding maybe what is their support system. Are you noticing of a grandparent or a sibling of an adult who's often coming to appointments, and just acknowledging, I see you were able to bring your mom this time, or whatever it is. Also, as children get older and are able to speak for themselves, when we're not talking about the little bitties, having part of a normal visit, just asking a child a one-off, what are you really proud of lately? What have you accomplished? So it gets, for everyone, even the adult, just seeing your interaction with the child is seeing that you're valuing not just what doesn't feel good, but what's feeling good too. And then that's a place to build from.
Great.
Yeah, I agree. I think, every family has unique strengths and experiences that really shape even how they approach medical care. So I think that question of what's going well, asking those, what have you accomplished so far in school, or what's been your most exciting activity outside, kind of really gives you an indication if there's a lot of school involvement, or there's a lot of church involvement, or there's a lot of community involvement. And that kind of helps you begin to understand what resources these families might be accessing. And then also building in that community and faith-based cultural pieces that people might be leaning into.
Great. Well, you're mentioning some positive events, which is wonderful. Can you give me an example of when it didn't go the way you had hoped, so we can learn what not to do?
I can share a story with you of where shared decision making did not go well for our family. So my son had been sick, and our provider was transitioning over to a new practice. And so we had to go to a walk-in clinic. And so my provider knows that my son comes with his own lived experience. And so she is very cautious, and she spends time just talking to just him, and, and really connecting with him before we move into a exam. And so we had to go to this clinic. And so I gave them the information that he had a trauma history, and that he would need to know exactly what was going to happen before we even went into the room. And so as we were doing that, they called our name, and already my son has his feet into the ground, and he's like, what's going to happen? What are we going to do? And so when we got into the room, I told the nurse, I said, he's really going to need to have some clear conversation about what's going to happen. He may even need to have a role in seeing how it happens, or what is an example. And so she said, okay, no worries. And so she got his blood pressure. And the next thing you know, literally in a blink of an eye, she has him pinned up in a corner doing a COVID swab and a strep test. And so he is like pushing her away and screaming, and it's a lot of commotion in there. And so once she leaves, I'm trying to calm him down. We're taking deep breaths. That did not go the way we anticipated it to go. So when the doctor came in, we told the doctor, we've expressed that he has a trauma history. If you could just let him be a part of what's going to happen, then that way he feels control and he can, feel comfortable within this exam. And the doctor says to me, we tend to baby this generation. And my mouth was just like, oh my gosh, but my son is still sick and I don't feel empowered to leave because he needs to have care. And so she listened to his heart, and then she started to look in his ears. And because there was him pushing that nurse away, she grabbed his arm and held it very firmly. And so I literally had to move her arm off of his arm. And so she stood up and she said, I think it's a virus. I think he'll be just fine, and left the room. And so that to me was when there was no collaboration before action. I expressed our values and our needs that we had, but power was definitely used instead of a partnership. They dismissed our lived experience and anything that we could have given for input, and they didn't even give us options or alternatives to what we could have done, from the get-go. So that to me was a time that we did not experience shared decision making.
Um, yes, that sounds like an absolute nightmare of a visit. Well, thank you for sharing that. It must have been incredibly painful for you to be there with your child going through that. So
Yeah,
I
I
guess,
was just shocked. I think that medical providers would have taken that stance, but I think everybody must have been activated. Like whenever he was having these tests done, I think the nurse must have gotten activated too, like fight, flight kicked in. And so then it just kind of went from there. And I immediately messaged our provider and I said, oh my goodness, I'm so thankful for you and the work that you do. And I can't wait till you get into the office.
yeah, I'm sure. Well, thank you for sharing that, Amy. I think what is so concerning about what you're saying is that you're right. It's the complete opposite of what we're hoping for all of our interactions. And it sort of talks about the intersection between a trauma exposure and shared decision making. And I think that's something really important that we might want to tease out a little bit, because I know as a provider, I've learned that if we look in the United States, about half of all of our children before 18 have experienced something that can be labeled as a trauma. That may not be the word they want to use, may just be a bad stressor, but it sort of means that all of us have to be educated about how best to deal with these children, because they are going to be there. And our job is to promote their resilience, right? To assess it and then help them move forward. So, can you give us examples of what would have been, you and Sarah, a good interaction where someone used trauma-informed care to help make shared decision making?
Yeah, and I think it goes back to, even if you have not disclosed that your kiddo has a trauma history like I did, I think the fact that you related, at least half of our kiddos have some kind of trauma before the age of 18, or a stressor before the age of 18. And that affects how people trust, how they communicate, how they make decisions. And so without using or without thinking about that trauma informed approach, even routine healthcare really can unintentionally activate fear or anxiety or withdrawal. So I knew all the right things to do for him, and I wasn't able to do them. I thought I had done them very clearly in saying and advocating for him. So I think really thinking about how we're using patient centered language. The provider said, we baby our kids. We're already in a heated situation. And so to say something like that to a parent who is dealing with a kiddo who has behaviors due to trauma, it's not that he wanted to be a bad kid. It was that he was literally scared that something bad was going to happen to him and that it was going to hurt. And so asking for permission before they did any procedure or physical touch is something that I would look for him. Offering choices for him, really respecting when he says no, and then what can we do without that? And if he says no, and respecting that and trying to understand why, I think are some of the things that we need to think about for a provider with a family who has had experience with trauma like that.
One idea in what Amy was talking about, and we know this as parents, we see it as providers. If there's a question that doesn't have two acceptable answers, may I do this? And no is not an acceptable answer. That's not the question you ask, right? You say, should I do this first or this first? You only ask the questions and offer the opportunities that are good. So if I'm hearing Amy's example, which was mind-boggling, if he was going to have a COVID test, you wouldn't say, may I give you a COVID test? You would say, we're going to have to do this. Should we do it before or after we talk about what this means? Or should we do the COVID test first or the strep test first? And those are social emotional ways to approach it doesn't have to be a child, any person in any situation that needs a response. Because the last thing we also want to do as parents or providers is to set our children up where we ask a question, they advocate for themselves by saying no, and then we say, actually, that's not an okay answer. I'm not going to listen to your no. So that's an important thing to think about. Or what are the options you're willing to take and are medically allowed to take as a response, and only ask questions where one of those answers is going to be okay.
Great advice. Well, Sarah, I'm hoping you can tell us an example where things went well.
I would be happy to.
Shared decision making actually came into fruition with your encounter with the provider.
Yes, we know that many providers do have a good job at shared decision making, and I'm happy to give an example. So we have a medical family. My husband's a physician. We're not afraid of medicine, and we're not afraid of mental health care or physical health care. That being said, we saw ideas that this was at the time our older child, but both children have tendencies to anxiety. And I guess this is an example of it's not a one-off conversation. So we brought up that concern when our kiddo was maybe 8. And at the time, the pediatrician looked at it, talked to us and said, I don't think we need to make any decisions yet. I don't think we need to do anything here. Here's what to watch for. And then at the time when he was 10 and it was the beginnings of COVID, and we reached back out and said, don't know if this is COVID, the environment, don't know what this is. It was an ongoing conversation with us at this point. And she said, I think we need to go ahead and talk to a psychiatrist or a psychologist. And she was able to provide names of people she knew, that she was already setting up the care team concept. Here are some people I can recommend and I know and I will work with and you will work with. And so as we pursued that, first it was just therapeutic interactions, conversations. And then after another couple years, when our kiddo seemed to escalate, and now it was time to consider an SSRI on top of, or some sort of medication on top of just his therapy. At that point, we had such a solid relationship with what felt like a care team that even though our initial pediatrician had retired, there were 2 other pediatricians at the practice who were regularly connected by cell phone with the psychologist. And it became a very easy conversation of the psychologist saying, here's what I'm recommending, talk to the pediatrician, talking to a pediatrician, they would confer or they would talk through us, and everybody. And now, even as they've aged, and both of our boys see this psychologist, and they're both on medication at this point that came at different times in different ways. As they grow, as we consider med changes, when we go in every 6 months for med check, it's such a supportive network. And while we are comfortable talking about mental health care and we're comfortable with treatment, the fact that this was so ingrained and it was clear as professionals, as a practice, that they were all networked and ready to support, that I can see how other patients and families who may not be as forthright or might be hesitant, they might just not know about the situation, there's a support system in there in knowing the left hand's talking to the right hand or is willing and able to talk to the right hand whenever it comes up. Because even no matter how much we're comfortable with something, or we know when it's our kid, we might even be on medication ourselves or have treatment of some form or fashion. And this could be, again, this could be a physical ailment, this could be diabetes, or it could be mental health. And we're okay with something, we're used to it for us. But then when it involves our kiddo, there's a whole nother level of emotion of, is this the right way? What are we doing? So just having that, our providers, even if we had not gone with this particular therapist or that one, our providers having some context of what was available in the community and being able to provide that was really helpful, because we have had situations in different worlds with schools where perhaps someone said, your kiddo needs a full scale evaluation. There's something going on with their reading. They need a full scale. And my example of not going well would be when I said, what does that mean? And the educator said, well, just call the OT. They'll understand what I'm talking about. I am an educator. I wanted to know from you. I wanted some definitions, some examples, some advice, some contacts. And if you're not providing that, you make the family feel kind of out to sea on a raft with no paddle. They don't even know where they're supposed to be.
Yeah, I think it's almost shame too, right? If you have somebody who says this, you need a full scale evaluation, you're all of a sudden like, oh no, what's wrong? Mm-hmm. It's not like, let's explore where his strengths and areas for improvement are. But all of a sudden you have the shame of a full scale. What in the world? And what does that mean? And for them not to fill you in on that really could have went a different way, right?
I try to remember, and I used when I was teaching, or I talked to my kids in situations that are for them, is remember, this can be somebody else's first rodeo. You might be very comfortable. You might see kiddos with anxiety or diabetes or whatever every day. But if you're bringing a new concern or a new noticing to a family, this may very well be their first rodeo with that. And so being prepared to define, to explain, and not just throw somebody out there and say, Google it, go WebMD that. No one wants that. Being able to provide context is so comforting and important to creating that relationship.
It's very helpful. I know that I've heard some families say to me that what they'd prefer, instead of somebody saying what's wrong with your kid, is what's strong about your kid. Mm-hmm. What are the things that we can look to build on as their strengths? Mm-hmm. Is that an approach that you feel resonates with you in terms of dealing with your children when they have these challenges that you want us to remember?
I think that's a great way to rephrase that. I think it also helps the kid, because sometimes when they're coming in for those challenges, they already feel kind of down in the dumps about, I can't move past this X, Y, and Z, whatever it might be. So I think when you really turn that script around and you're asking about strengths, then not only does the parent and the child all of a sudden say, oh, he's really good at this, and can we use what he's really good at to help with this other challenge? And so I think using that strength approach like that really changes the conversation and probably the energy in the room.
It would absolutely change the energy in the room, definitely. And I think it also is an acknowledgement that every child, every patient is going to be different. So knowing their strength is going to be critical for them to see success, because what you may recommend for one child is not going to work for another child if their underlying strengths are different. So I think it's an absolute, it's not just nice, it's an absolute need to know so that you can set everyone else up for the most likely positive outcome.
What should we be sharing with the school? And is the school going to be a resource where you can maybe find some help when there isn't enough help out in the community? Or is a school a place where you don't really want them to know that much about this side of your child? Can you ladies speak to what you think your advice would be for the pediatricians and primary practitioners who are listening?
That's a great question, because it weighs on parents a lot too, right? What are people going to think about my kid? What's the right thing to do? And so I suppose I'd start out with, it's okay to ask that question, and also to let families know either option is okay. They don't have to make that decision early on. You can start one way, or be rather conservative in what you share and then tell more. You can ask, maybe you're trying to figure out too, is the school someplace where the family is going to feel support? How involved are they in the school versus how involved are they with outside the school activities or community? So you can start to lay those little crumbs. But I also get it when, Amy and I as parents have said, oh, well, you can ask this and you can discuss this. And you may be listening to this and thinking, yes, and I could also, fly to the moon if I had all the time in the world and all the opportunity. And so I think that's where we go back to what we talked about at the very beginning of, if you can discuss just one thing for a couple minutes every visit before you have big shared decision-making moments, then you don't have to cover all of that territory in one visit. When something comes up, you have some feedback from earlier, and then you can say, we know that you may want to take this to the school or not. Do you know, for example, from what we're talking about now? And the family might say, yes, I absolutely want to let the school know this situation, or I'm not really sure. And then having a mechanism within your practice, your system, whether you use an electronic, a patient portal type of thing where somebody can drop an email, or whatever your system is, where you can say, okay, you don't need to know right now. If you decide you want support like that, let us know later on. And then you can also know for your practice, am I going to set up a targeted visit time? Is this something that my nurse might have? We have something already set up and they can provide, because we do realize that everything sounds fantastic and it can be tough to actualize. So if you can have a good relationship, a lot of things can come from that, and it can breathe and not be everything all at once.
Great.
Yeah, and I think for me, the thought of, even as much as I trust my provider, for them to say, would you like us to work with the school, scares me. It makes me a little bit worried about, I haven't disclosed to them that he's had trauma. I let him go to school because I wanted him to make his own way without any kind of prejudice or anything like that against him, or somebody coming in with a judgmental eye for him. I did let them know that he had testing, and that testing was available for the school district to look at, should they look at it. And so that kind of, it makes me pause and think, do I want the school and the medical side to connect? And what does that look like really? And so again, I think that's a conversation that you would have for shared decision making, maybe before that time gets there. And again, absolutely goes back to that foundation that provider invested in. Is there going to come a time when I'm going to need her to step up to the plate with me? There very well may be. And I have already have this relationship with her. So I feel that I could reach out and say, I need help. And then we can go about it as a team, knowing what medically is good for him, and then what lived experience that I can advocate for him. And so that is a tricky one, Dr. Bloomfield, because I think it really comes down to the provider knowing their family and knowing what support to give. And again, like Sarah said, doctors often are afraid to ask the questions. So I think asking in small chunks, and maybe it's that you begin to set up a system of, I'm going to talk about this one piece of information at each visit till I get, the 10 questions that I need to know most about this family completed. Or, you just can't ask all the questions at one time. We know that you don't have that much time. Most providers have 10 or 15 minutes. And so really getting to know that patient over the long haul, and you're really investing in them, I think is the most important thing.
Great. Well, I know that primary care practitioners look forward to longitudinal relationships. That's why most of us go into this, to watch these kids grow. I like the ideas that we should do it a little at a time. It could be overwhelming on both sides, right? If we all just try to go through all those questions at once. And you make a good case for frequent visits before a kid starts school, right? We talk about school preparedness a lot. Sounds like you're telling that's part of what we should help families prepare for. What do they really want us to do? So this has been fascinating for me. I'd really like to know if you have any last thoughts that you want to share with our listeners, things that they should really remember.
I would say to providers from our family's experience, I think one of the most important things to understand about shared decision making, it's not just about choices. It's really about feeling safe, feeling respected throughout the whole process. When trauma is a part of your story, or mental health challenges are a part, decisions really can feel overwhelming, even activating, if we're rushed into and asked to make decisions and not really having clear explanations. So, what truly empowers us is when providers really slow down and they take that time to listen deeply. I think that empowers us. And I think to families, I would say you're the experts. You're the experts in your life and in your child's life. You know what's going to work, but it's also okay to ask questions, to say when you need more time to make a decision, or when something doesn't feel right. It's your feelings, your insights, and they are very important to this whole care process.
Great.
I would say that perhaps counterintuitively, being very good at shared decision making also strengthens when we can't have shared decision making.
Yeah.
If a family trusts that you will provide an opportunity and a choice when there is an appropriate one, then whenever the situation arises when there isn't an appropriate choice and there needs to not be shared decision making, but a direction, a medical direction, the family is going to be able to trust that you have their best interest and their child's best interest at heart, because you have set yourself up in that relationship to say, anytime that there is a possibility to share, we're going to share that burden. And when it's not responsible for me to give you, to set up a shared decision making or to ask, but I really need to strongly advise or to tell you how we should be moving forward, the family's going to trust that with greater fidelity as well.
Oh, great. These are great lessons. Thank you so much. I'd like to close with a quote that I always try to remember when it comes to doing shared decision making. It comes from Maya Angelou. She said, "You may not control all the events that happen to you, but you can decide not to be reduced by them. Be bold enough to use your voice, brave enough to listen to your heart, and strong enough to live the life you imagined." And I want to thank both of you for speaking from your heart about your experiences as moms and advocates for your children and for your community. It was a pleasure meeting with you today.